We have started this project 4 years ago, CNA ablation, and it's great era in our lives that we have opportunity to help, especially young generation, in terms of conduction disease, because before it was only pacemaker. Now we have some data, and I'd like to show you some information about this. So automatic nervous system, you know better than me, but the cardiac ganglia is including more parasympathetic. So intramurally, we have more parasympathetic innervation. That's why when we do cardioneuroablation and ablate from the heart, inside the heart, we are just touching parasympathetic nervous system, and is for us it's the parasympathization of the heart. So some articles shows that nervous system, parasympathetic nervous system is located in right and left atrium, but we have some ganglionic plexi for sinoatrial nodes, especially for AV nodes, especially, and mixed ganglionate plexus as in sinoatrial and AV nodes, for a sinoatrial and AV nodes. And our approach is empirical, so-called empirical, automatic guiding. So we have 3D system. We are just analyzing our 3D system, finding the ganglionate plexi and ablate. Everything easy. But we know, electrophysiologist knows that some ganglionic plexus are located for, where the ganglionic plexus is located for AV node, where is ganglionate plexus located for the sinoatrial node, and we are trying to reach these special ganglionate zones. First of all, we should find so-called Hafe and Lafe potential. So it's high frequency and low frequency oscillations that we are find spikes to oscillations or spikes to find ganglionate plexus plexi. And we have I'd like to show you especially our trial about AV node disease, AV node dysfunctions. I mean, also, always when I'm telling AV node dysfunctions, I mean functional dysfunctions, not in the organic problems. So we were performing before extracardiac vagal stimulation for identification of this sinoatrial atrioventricular node problems. And Pachon and co-authors shows that when they were performing extracardial vagal stimulation before ablation and doing some ablation for sinoatrial node, after the ablation, they understand that they have still asystole after doing the ganglionate plexi ablation for the sinoatrial zones, and they perform after ablations for the AV node, and extracardiac vagal stimulation shows better results, no AV block. So they were sure that different CNA approaches for AV node needs always extracardiac vagal stimulation before and after ablation. You see now the example of extracardiac vagal stimulation with 30 to 50 hertz, 30 to 70 volts. So it's high frequency stimulation, and you see this outcome after high frequency stimulation. After ablation, they solve these problems. So let me tell you about our single center study where we enrolled two groups of patients with functional AV block. In first group, it was so-called conventional approach, classical approach, what the vast majority of the authors are using. And it means posterior middle left ganglionic plexi ablation, posterior lateral ganglionic plexi ablation, and so on. with extracardiac vagal stimulation, uh, biatrial approach, and atropine test we are performing always before and after ablation. So atropine test was positive before for those patients. And ablation electrodes, we are putting the filters from 200 to 500 hertz. It's always like our protocol. And we are trying to perform high density mapping. And another group, we call it mirror method because it was 31 patient with only posterior middle left ganglion plexi ablation. So it was left, it's like, it's not only left and right, but it's always this pyramidal space with this group patient. And we don't use in this particular group with extracardiac vagal stimulation. So it was always performing Wenkerbach point and don't use extracardial one. We are electrophysiologists. We believe that we have a EP study, and it's in this group we believe that it's more than enough. It was biatrial approach. Atropine test here also was before was positive, and the same parameters we are using in the conventional groups, ablation on the ablation electrode, 200 to 500 hertz filtering. So, and our study, we have not a lot of time. That's why I'd like to conclude our study. Showed that significant difference between two groups in regards of long-term success rate. It was quite similar. So, conventional group and so-called our mirror method shows the same results, and it was about 96%. Let me show you our mirror method protocol. If our patient has functional AV block and needed intervention, we are doing for all of them atropine test before procedure. If atropine test shows us positive result, and it means PR interval is shortening, we are performing for those patients cardioneuro ablation. If we have acute success, it's good, and our patients are we are performing for patients 44 hours after 44 hours after CNA Holter monitoring, in 7 days, in 30 days, and after every 3 months we are performing this Holter monitoring, and continuous follow-up. It's like very mandatory here. If not, we have not good success rate, we are putting pacemaker for those patients. It's one of the our patient with so-called mirror method focused on precise ablation of posterior middle left ganglion plexi and bilateral, and without utilizing extracardiac vagal stimulation. Patient with paroxysmal AV block, third degree AV block, and you see the EP study where we show the it's quite normal AH and HV interval. She was 26 years old lady, refused pacemaker, and we performed this ablation in I call this space especially as a pyramidal space. We are doing some septal or paraseptal accessory pathways, left and right side, and we are showing to you these Haffe and Laffe potentials, what we are finding in ablation catheter. And for us, it's very important before CNA and after CNA, antegrad Wenkerbach point, that changing, and it's changing from 480 to 400 after before 480 to 400 after ablation. So if the 20% we are reach 20% enlargement of Wenkerbach, lowering Wenkerbach point, improving Wenkerbach point, that we understand that we are in good spot, because for us 20% of changes of Wenkerbach, it's good prognostic point. So after follow-up, 18 months, we have follow-up for this young lady, and you see acceleration of sinus node, no single atrioventricular block episode, and you see in the bradycardia also sinus bradycardia, but we have not AV block more. So it was not single even AV block episode in 18 months after radiofrequency ablation. Another lady, for me, it was surprised because 59 years old female, and 59 years old female, I mean, the all data shows that it's cardionatal ablation works better in less than 15 years old persons, but this lady was without any structural heart disease, without coronary artery disease, and you see the AV block more than 5 or 6 seconds, paroxysmal AV block, and we perform monolateral, only right-sided ganglionoplexy ablation, and we had plus minus the same result in this lady. She has not even single episode of syncope after ablation, single episode of AV block, and that's why we understand that it works. This method works in the people more than 50 years old without any structural heart problems. So we are now involved in multi-center, multinational study. It's PIRE CNA. We just published it in Europace, and it's more than 125 patients were involved in this study, and 96 percentage of success rate. So I think this method is promising method. Just we need more data, and this is the point in which we'd like to collaborate with Chinese colleagues, our Asian colleagues, to improve our skills in this direction. Thank you very much for your attention, and I'm ready to answer your questions.